Usually when we talk about how our bodies react to things, we expect, simple engineering, like you push a button and a light turns on.
Right, you take a painkiller, your pain goes away.
Exactly. It feels binary, it feels clean. We want to view our biology as this predictable machine that just obediently accepts whatever inputs we give it.
But the moment you step into the world of pharmacology, well, specifically how human biology adapts to drugs over time, that simple machine analogy just completely falls apart.
It really does.
Yeah, you realize you aren't dealing with a machine at all. You are dealing with a dynamic, incredibly stubborn ecosystem that constantly fights back.
Which is exactly our mission for this deep dive.
Yeah.
We are unpacking the fascinating and honestly wildly misunderstood reality of how our bodies respond when they are repeatedly exposed to a chemical.
Right.
We're going to dig into the specific mechanics of tolerance, dependence, and withdrawal. Because this isn't just about illicit substances, These are the fundamental biological rules that govern everything. From how surgeons keep you under anesthesia to how everyday blood pressure medications work.
And to bring this right down to earth for you listening, I mean, if you have ever woken up, skipped your usual morning cup of coffee, and felt a throbbing headache creeping in by noon, well, you have personally experienced mild physical dependence and withdrawal.
Oh, the dreaded caffeine headache. It happens to the best of us.
Yeah, but that headache isn't some sort of moral failing or weakness. It is a straightforward biological mechanism. Your body was expecting a chemical input, it pre-adjusted for it, and when the chemical didn't arrive, you felt the internal gears grinding.
Okay, let's unpack this. Imagine your body is a highly advanced thermostat. You have it set to a comfortable 72 degrees. If you open a window in the middle of winter to freeze the room out, that thermostat doesn't just sit there and let the room freeze.
No, it aggressively cranks the furnace to fight you.
Exactly, trying to maintain its baseline. It pushes back against the cold.
That is a perfect visualization for the core biological principle at play here, which is homeostasis. Your body is built to aggressively defend its set points. Your heart rate, your body temperature, your neurotransmitter levels.
Right.
Any drug, by definition, is an external force that pushes one of those physiological systems away from its natural set point. So in response, your body launches a compensatory adaptation. It pushes back in the exact opposite direction.
So if a drug is a chemical push, tolerance is just the body's counter push canceling it out. As long as you keep taking the drug, the push and the counter push just sort of meet in the middle.
Exactly. The exact same dose of the drug simply does less over time because the thermostat is pushing back harder.
But that makes me wonder about the flip side. Like, if you suddenly remove the drug, well, that counter push is still running.
And that unopposed counter push is exactly what withdrawal is. When the drug is removed, that massive biological compensation has nothing left to push against. To look at what that actually means inside the body, consider a chronic stimulant user. A strong stimulant floods the brain with dopamine, creating a massive chemical push. To maintain homeostasis, the brain's thermostat downregulates its own natural dopamine signaling.
Oh, so it essentially turns down the volume on its ability to receive dopamine.
Precisely. Meaning, if the user stops taking the stimulant, they don't just return to normal. They are left with a brain that has artificially muted its own dopamine system. So they experience a massive dopamine-deficient crash of fatigue and depression.
The furnace is still running, but the window is closed.
That's a great way to put it. Consider another example at the opposite end of the spectrum, like a chronic heavy drinker. Alcohol is a powerful depressant. It heavily sedates the central nervous system.
Right, it slows everything down.
Yeah, so to fight this sedation, the brain suppresses its inhibitory signaling, a calming chemical called GABA, and massively ramps up its excitatory signaling, a chemical called glutamate.
So the brain is essentially hyping itself up just to stay awake under the heavy, wet blanket of alcohol.
Exactly. So if you suddenly pull the alcohol away, you're left with a brain that is practically vibrating with excitatory glutamate, and it has almost zero inhibitory GABA to calm things down. The brain is entirely hyperexcitable.
Which is mechanistically why severe alcohol withdrawal can cause deadly seizures, right?
Yes. The nervous system is over-revving with absolutely no brakes.
Wait, so are tolerance and withdrawal basically just two sides of the exact same biological coin?
They really are. What's fascinating here is that the psychological framework for understanding this push and pull was actually solidified decades ago. In 1974, researchers Richard Solomon and John Corbett published the opponent process theory.
Oh, right. They give this whole biological dance a very specific vocabulary.
Yeah.
They propose that any strong stimulus triggers a primary response, which they called the A process.
Correct. So the A process is the direct effect of the drug, the euphoria, the pain relief, the sedation. But that A process automatically triggers a secondary, opposing, compensatory response from the body itself, and that's the B process.
And here is the critical mechanical detail they discovered. Over time, with repeated exposure, the A process, the drug's direct effect, stays exactly the same.
Right. A milligram of a chemical is always just a milligram of a chemical.
But the body's B process, that biological counterpush, gets stronger. It kicks in faster and it lasts significantly longer. So the net effect you actually feel shrinks over time.
Yes, the B process gets ripped like a bodybuilder, while the A process stays the exact same size. That shrinking net effect is tolerance.
But when you remove the drug, that massive muscular B process dominates the entire experience for days or even weeks, and that is withdrawal.
Exactly. Tolerance and withdrawal are not two separate biological phenomena. They're the exact same mechanism, just viewed at different points in time.
That reframes the entire concept beautifully. But this counterpush isn't just one single action happening in one place, is it? The body is incredibly resourceful, and it fights the drug on multiple fronts.
It really is. Pharmacologists generally split this into three distinct mechanisms. The first is pharmacokinetic or metabolic tolerance. This mostly happens in the liver.
Okay, so think of your liver as the body's waste management system.
Right. If someone drinks heavily for a long time, the liver literally gets better at destroying the alcohol. It induces a specific enzyme known as CYP2E1 to break down the chemical faster.
So the body recognizes a recurring toxin and responds by building more molecular garbage trucks to clear it out before it can even reach the brain.
Precisely. Then you have the second front, which is pharmacodynamic tolerance. This happens down at the cellular level. If you take chronic opioids, your opioid receptors, the actual binding sites on your cells, change.
How so?
Well, imagine a cell has 10 keyholes that the drug can unlock to produce pain relief. Over time, the cell will literally internalize some of those receptors. It swallows the keyholes, pulling them inside the cell wall where the drug just can't reach them.
Wow. So even if the drug makes it past the liver, the cell itself has muted its own response.
Yeah, it is a stunning display of cellular self-defense.
Mm-hmm.
The same amount of drug is in the blood, but it produces a fraction of the cellular response.
Here's where it gets really interesting, though, because there is a third type of tolerance that completely blew my mind. Behavioral or conditioned tolerance.
Ooh, yes.
This suggests that the biological pushback doesn't just happen autonomously inside the cells or the liver. It actively involves the outside world.
It is a genuinely strange and deeply underappreciated phenomenon. To understand the mechanics of it, we have to look at a landmark 1982 study by psychologist Shepard Siegel. He was working with laboratory rats,
Giving them repeated, gradually increasing injections of heroin right until they developed a very strong tolerance to the drug.
Exactly. But the key to Siegel's experiment was the setting. He administered these doses in a very specific familiar environment for the rats, a particular cage with specific lighting, specific sounds, and specific smells.
So the rats learned to expect the drug in that exact setting.
Right. Then, Siegel took a subset of those highly tolerant rats and gave them the exact same high dose of heroin, but he administered it in a completely different, novel environment, a room they had never seen before.
And what happened?
The results were staggering. The rats given the drug in the unfamiliar setting died from overdoses at dramatically higher rates than the ones dosed in their familiar environment.
Wait, really? Even though the chemical dose was absolutely identical down to the microgram?
Yes.
Exactly identical. It's like Pavlov's dogs. Pavlov rings a bell, the dogs drool because they expect food. Siegel's study proved that the environment itself, the familiar cage, the room, the smells, it acts as a sensory cue.
Exactly. The brain recognizes the room and literally pre-arms the body. It triggers all those internal defensive countermeasures, the B process, before the drug even arrives in the bloodstream.
So the environment becomes part of the tolerance mechanism. In the familiar cage, the rats' bodies braced for impact.
But in the new cage, without those environmental cues, the body was caught completely off guard. The B process didn't deploy in time, so the quote-unquote tolerated dose suddenly behaved like a massive, unprepared-for dose.
That is terrifying.
It is. Siegel later found strong supporting evidence of this in human heroin overdose cases, where users took a routine dose they usually handled fine, but because they took it in a strange location, like a different city or a strange hotel room, it became lethal.
Which brings up a critical, counterintuitive point about how tolerance fluctuates in the real world. Think about this logically for a second. If building tolerance requires taking more and more of a dangerous drug, you would naturally assume that losing that tolerance, say, by going sober for a few months, would make you inherently safer. You reset the thermostat back to zero.
It is a totally logical assumption, but clinically it is a fatally incorrect one. Losing tolerance is often the most dangerous thing that can happen to a person. Yes. There is a deeply impactful 2007 study from the New England Journal of Medicine by Dr. Ingrid Binswanger that illustrates this perfectly. She followed former inmates released from Washington state prisons.
Right, these were individuals who had been incarcerated and therefore forced into abstinence from their usual drug supply for months or years.
Exactly.
So during that time in prison, their bodies metabolically and cellularly reset. They lost their tolerance. The keyholes came back to the surface of the cells, the liver stopped producing extra enzymes, the thermostat returned to normal.
But her study found that upon release, their risk of death in the first 2 weeks was roughly 12.7 times higher than the general population.
Wow. 12 times.
And the overwhelming leading cause of death was drug overdose.
Because their mind remembers the old dose, but their body has forgotten how to fight it.
That is exactly the mechanism. Before incarceration, their B process was strong enough to withstand a massive amount of a drug daily. Upon release, they often return immediately to a dose calibrated to that old pre-prison tolerance level.
But without that muscular B process to push back, a dose that was perfectly survivable a year ago is suddenly lethal.
Exactly. This biological misunderstanding of how tolerance resets is why modern U.S. correctional health policy has dramatically shifted. It's why there is now a massive focus on providing naloxone, the overdose reversal drug, and medication-assisted treatments right at the moment of release.
It's wild to think about how long it's taken modern medicine to adapt to the realities of this, especially considering humanity has intuitively grasped the basic concept of tolerance for millennia. I mean, look at King Mithridates VI of Pontus over 2,000 years ago.
Oh, right, the Poison King.
Yes. He was so terrified of being assassinated that he deliberately took gradually increasing sublethal doses of various poisons to build up a bodily resistance to them. They still call the practice Mithridatism.
The ancient historical details might be slightly embellished, but his intuitive grasp of the biology was completely sound. Repeated sublethal exposure fundamentally changes what the human body can subsequently withstand. The body adapts to survive.
But moving from ancient kings to modern medicine, the historical record shows that the medical community really struggled to clearly define these biological facts. Up until the 1930s, withdrawal was often completely dismissed by doctors as just a weak will or a moral failing of the patient.
Yeah, it was a deeply flawed perspective.
Yeah.
The major paradigm shift didn't happen until a physician named Clifton K. Himmelsbach began working at the U.S. Public Health Service Hospital in Lexington, Kentucky, colloquially known back then as the narcotic farm.
Right. Himmelsbach decided to actually quantify what was happening during withdrawal. He created the Himmelsbach scale.
He did. He stopped listening to subjective complaints and started measuring objective, observable physical signs: pupil dilation, goose flesh, vomiting, severe changes in blood pressure and body temperature.
By tracking these physiological metrics, he proved unequivocally that withdrawal wasn't in the mind. It was a severe physical event you could track on a chart, just like a fever or an infection.
Exactly. He established that dependence was a biological reality. But even with those concrete measurements, the terminology got incredibly tangled up in the following decades, leading to catastrophic public health crises.
How so?
Well, if we connect this to the bigger picture, the most disastrous semantic confusion in modern medical history has been the conflation of physical dependence, which is just the biological adaptation of the thermostat we've been discussing, with addiction, which is a behavioral and motivational disorder characterized by compulsive use and loss of control.
So if I'm a cancer patient taking a prescribed pain medication exactly as my doctor ordered, my body will naturally build tolerance, the cells will downregulate receptors, and if I stop taking the medication abruptly, my body will experience physical withdrawal.
Yes, your body's behaving exactly as it should. But the psychiatric community completely blurred the lines between that biological reality and behavioral addiction. The DSM-IV, published in 1994, listed tolerance and withdrawal as core criteria for a diagnosis they called substance dependence.
Wait, but they were using the word dependence to mean what the general public understands as addiction.
Exactly.
So if they define substance dependence just as having tolerance and withdrawal, that means a totally normal cancer patient would fit the criteria for a severe psychiatric disorder just for taking their medicine correctly.
Yes, unfortunately. Under the DSM-4's flawed logic, because you showed biological tolerance and withdrawal, you were scored toward a diagnosis that looked practically identical to addiction. It wasn't until the DSM-5 in 2013 that they finally fixed this.
By renaming the category substance use disorder.
Yes, and explicitly carving out an exception. If tolerance and withdrawal arise solely from appropriate medical treatment, they do not count toward an addiction diagnosis. You can be profoundly physically dependent on a standard antidepressant or a beta blocker for your heart and never meet a single behavioral criterion for addiction.
But before they fixed that semantic confusion, it was heavily weaponized, tearing the medical community in two entirely different, equally destructive directions.
Absolutely. In the late 1990s, the pharmaceutical industry, most notably Purdue Pharma, leaned heavily on the distinction between manageable physical dependence and real addiction to market OxyContin. They utilized a very brief one-paragraph letter to the editor, published in 1980 in the New England Journal of Medicine by Gene Porter and Herschel Jeck.
It was literally just a short letter reporting low addiction rates among hospitalized patients receiving acute pain relief. It wasn't a rigorous long-term outpatient study at all.
Yet it was cited for decades as hard evidence that opioid pain relievers carried minimal addiction risk for chronic pain patients. Sales materials heavily promoted the concept of pseudo-addiction.
Right, this was the idea that if a patient was showing aggressive drug-seeking behavior, they weren't addicted, they were just undertreated for their pain.
And the suggested solution, conveniently, was simply prescribing a higher dose of opioids. They conflated the reality of predictable biological tolerance with the dangerous, unfounded assumption that the patient was somehow immune to the behavioral disorder of addiction.
But consider the flip side of that coin. A few decades earlier, that exact same misunderstanding caused a totally different disaster, a phenomenon known as opiophobia in the 1970s and 80s.
Yes. During that era, many clinicians were terrified to prescribe adequate opioid doses, even to terminal cancer patients. They conflated the inevitable, normal physical dependence those patients would develop with behavioral addiction. They were treating basic biological tolerance as a moral red flag.
The tragic result was that terminal patients died in unnecessary agony because their doctors misunderstood the pharmacology.
The World Health Organization actually had to step in and formalize a pain relief ladder in 1986, just to correct this specific fear.
It is incredible how dangerous a misunderstanding of a basic biological concept can be, which makes it really important that we clear up some lingering myths about how this all works today, because we've been talking about tolerance as if the whole body just gradually goes numb. But does the whole body actually build tolerance at the exact same rate?
That is a major and very dangerous misconception. Tolerance is not a single uniform process that scales evenly across your whole body. Let's look at opioids again. A user's brain will develop tolerance to the euphoric high very quickly. The brain will also develop tolerance to respiratory depression, the slowing down of the breathing reflex.
Okay.
However, the body develops almost zero tolerance to the drug's effect on the digestive tract.
So the brain adapts to the FI, but the gut never gets the memo, which is why chronic users suffer from severe constipation regardless of how long they've been using.
Correct. And this differential tolerance is precisely why overdose risk remains so incredibly high, even in very experienced users. Their tolerance to the euphoria builds so incredibly fast that they have to keep drastically escalating their dose to chase the high.
But their tolerance to respiratory depression doesn't build nearly as fast.
Exactly. Eventually, their pursuit of the euphoria completely outstrips their breathing safety margin, and their lungs simply stop.
So tolerance isn't a straight, predictable line where everything just gets safer. Sometimes, repeated exposure actually does the exact opposite of tolerance.
Yes, this is a phenomenon known as sensitization or reverse tolerance. With certain drugs, particularly heavy stimulants like cocaine or amphetamines, the euphoric high might diminish, which is classic tolerance. But other effects, like psychomotor activation, which is essentially the physical revving up of the nervous system causing agitation or paranoia, can actually grow exponentially stronger with repeated exposure.
So different parts of the same brain are reacting to the exact same drug in totally opposite directions. One part gets numb, the other gets hypersensitive.
Exactly. A highly related and deeply concerning phenomenon is kindling, which is very well documented in chronic alcohol withdrawal. Think of kindling like repeatedly bending a weak piece of metal back and forth, or a dry forest catching fire easier with each spark.
So every time a chronic drinker goes through severe withdrawal, the brain gets progressively neurologically scarred and sensitized.
The stress compounds. This means that each subsequent attempt to detox is statistically more severe and much more likely to produce deadly seizures than the last one.
It's why unsupervised DIY alcohol detoxes for chronic users are highly medically discouraged. The brain is primed to explode. Which brings up a really scary thought about all of this. If the brain is kindling or sensitizing, does the thermostat ever actually go back to normal? Like, does tolerance ever truly go away?
This raises an important question, and it's one of the most heavily debated areas in modern pharmacology. The traditional view was simple homeostasis. You remove the drug, weather the storm of withdrawal, and the body eventually resets perfectly to normal.
But I'm guessing that's not always true.
Right. Researchers George Koo and Michel Lemol developed a different framework called the allostasis model.
Allostasis, how does that practically differ from homeostasis?
Homeostasis means returning to the original baseline. Allostasis suggests that with chronic, heavy drug use, the body's set point doesn't just get temporarily displaced, it permanently shifts to a new, altered baseline. The zero on the thermostat gets physically moved.
Wow. So some of those biological countermeasures, the B process, never fully reverse, even after years of complete abstinence.
Right, the body is forever changed. The ecosystem is permanently adapted. In many measurable ways, yes. It creates a persistent neurological vulnerability.
Have we seen that clinically?
We see this clinically with drugs like benzodiazepines. The British psychopharmacologist Heather Ashton documented this extensively. Her withdrawal protocol, the Ashton Manual, is based heavily on the clinical reality that some patients experience protracted withdrawal.
Like a lingering sub-threshold vulnerability.
Exactly, and a host of neurological symptoms that can persist for months or even years after the drug is completely gone from the body. The chemical is gone, but the biological footprint remains.
This is absolutely staggering when you pull back and look at it. We started with this basic idea of a thermostat pushing back against a chemical, but we've seen that this pushback involves liver enzymes building molecular garbage trucks, cellular keyholes disappearing inside the cell wall, and even the environment acting as a Pavlovian trigger to brace for impact.
And we've seen how confusing the biological facts of dependence with the behavioral disorder of addiction created massive, tragic crises in both pain management and the modern opioid epidemic.
And we've seen that these mechanisms aren't just academic concepts for pharmacologists to worry about in a lab. They dictate how anesthesiologists must carefully dose surgical patients, how psychiatrists must meticulously taper antidepressants so their patients don't suffer a neurological crash.
And why emergency responders know that a person is statistically most likely to suffer a fatal overdose, not when they're using the most, but right after they've gotten sober and their tolerance is completely dropped.
So what does this all mean for you, the listener? It means that your biology isn't static. Every single time you introduce a chemical, your body is taking notes, it is adapting, and it is preparing for the next time. You are not a machine waiting for inputs. You are a living, breathing ecosystem desperately fighting for balance.
And that fight for balance can lead to incredibly counterintuitive biological outcomes that we are still struggling to manage in modern medicine today.
Perhaps the most mind-bending example of this is a clinical phenomenon known as opioid-induced hyperalgesia.
Hyperalgesia. Breaking that down, that means an increased sensitivity to pain, right?
Exactly. It is a biological paradox where taking chronic opioid pain medication over a long period actually causes the nervous system to adapt by becoming vastly more sensitive to pain overall.
Oh, wow.
The B process, the body's counterpush, overshoots the mark so aggressively that it turns the body into an actively pro-pain state. That is wild. The medication you take to stop the pain eventually becomes the exact physiological reason you are feeling more pain. The thermostat pushes back so hard it completely breaks the thermometer.
It forces us to ask a very uncomfortable question about the future of medicine. How do you effectively treat chronic pain when the biological cure eventually becomes the root cause of the suffering itself?
It's a question that shows just how complex our internal ecosystem really is. Every action has a reaction, and in human biology, that reaction is always trying to rewrite the rules.